I have been told by 3 different doctors that I am obese. Help me understand why somebody in a professional medical field would label me as such.
They unfortunately are looking at one number, a BMI. It doesn't take into account really anything else. Unfortunately, we are missing the mark with only looking at a BMI. The easiest way is a body composition like an impedance scale. That currency, how it goes through muscle and bone and fat and water, it'll give us numbers. That's a better way of us seeing whether or not someone is truly overweight. And so many people would be missing the mark because unlike your story where they're saying you're in the obese range, this person is saying, oh, your BMI is fine, but they're actually metabolically obese. That's more dangerous.
This episode is brought to you by OneAccord. If you're a business owner thinking about a transition or exit in the next few years, listen to me. The number one reason that companies fail to sell or sell for far less than they should is really simple. The business still depends on the owner. You've heard it 1,000 times on this podcast. OneAccord's Oasis strategic planning and execution system helps owners build leadership alignment, operational clarity, and discipline execution so they can run and grow without them. That's what creates valuation lift. That's what makes you buyer ready. Everything that I don't tell you listeners get an exclusive free value readiness snapshot to see exactly where your business stands today. All you have to do is go to oneaccord.co/oasis. That's OASYS/Josh Zolin. That's me. oneaccord.co/oasis, OASYS/Josh Zolin to get your complimentary value readiness snapshot today. Now, let's start the show. If I'm a new patient, you have never seen me before in your entire life, and I walk into your office, what is the first thing that you ask me, that you do in order to understand, have a complete picture of who I am and my overall wellness?
Yeah, great question. So I do things a little non-traditionally, that when someone is wanting to make an appointment with me, they have unfortunately, it's about 10 pages to fill out before they see me. And the reason why I have them start filling that out is it gives me a feel for what their history has been, what they're looking to get out of an appointment. And I like to actually order some blood work and records before I see a patient, because then I feel like I've done a little bit of the legwork and we can have an even better conversation. So our first appointment is actually an hour long. And I do have some patients who might need to be longer than an hour. And that's because of their medical history. And I want to make sure that I'm able to really understand everything they've been through and all of their goals that they have too with their healthcare journey. Yeah.
So in the blood work and the records, what is it that you're looking for? Are there certain things that you look for?
Yeah, I am looking at a larger panel than most physicians know to order, and that's because I'm a cash pay practice. So I feel that I can order things that are important that potentially may not be covered by insurance or standard of care. So I'm not looking for the typical things of just, are you anemic? What are your kidneys and liver looking like? I'm looking deeper dive into your hormones, your thyroid, nutritional deficiencies. Do you have inflammatory markers? Like, you don't have to come to me and say, I have joint pain for me to look at your inflammatory markers. I want to know whether or not they're elevated, because it might lead me to ask better questions. And you might think like, oh my gosh, I am having some issues with weight loss or hair loss or GI symptoms or skin issues, where it's not your typical, my thumb is inflamed. And now I go looking for, do you have an inflammatory marker that's up?
That's interesting. So would you say that most of the patients that you see come to you because they have an ailment, or is it more of a proactive approach where they want to make sure they get ahead of anything that could happen and then discover this stuff through the process?
Yeah, I would say both.
Yeah.
With I've been in practice for almost 20 years now. And so my initial practice was, I knew I didn't want to do geriatrics. I loved internal medicine, but my average age of patient in my first practice back in 2006 was 85. And I knew right away, one, I loved seeing them. I noticed that they had what was called polypharmacy, just way too many medications. So I would start to wean back on their medications to help them feel better. But in that first year, I learned that I really want to do preventative medicine. And my desire was about 35 to 65. It was what I wanted to be my average age of patients. And then I was blessed to, started practice through a hospital organization. And that taught me that I did love internal medicine, traditional internal medicine. But I did not enjoy working for a hospital long term, and it being insurance based, where I had to continue to look at what was covered, what's not covered, or patients just thinking they saw me when they're sick, because I would always introduce myself and say, we might see each other, often right now, but my goal is to keep you healthy and out of my office. So at least once a year, I want to see you so I can see how you're aging, what's going on. And then I got into obesity medicine because I really felt that helping people lose weight was important. I could get rid of a lot of their medications, help them feel better by helping them safely lose weight. And then in 2019, actually, it was 6 years ago yesterday, I opened my own practice. So
6 years ago?
6 years ago yesterday.
Congratulations.
Yeah, thank you. That was the soft opening. The grand opening was February 14th of 2020, right before COVID.
What a time.
We had to really pivot then, where I was like, a grand opening, we always joke that was the first super spreader. We didn't know that having 50 people in one room was not good. So yeah, I know that was maybe too long of an answer. But
No, that actually helps me a lot, because with that one answer, I have come up with 50 questions in my head.
I love it.
To ask. So I'm gonna start by asking, what didn't you enjoy about working at a hospital? And I'll ask one question at a time.
Okay.
What didn't you enjoy?
I will tell you that I enjoy taking care of the whole patient, and I actually love taking care of families. And so when I was hospital-based, it's very acute care, and I didn't get to follow them. So if it was someone, let's say, who came in needed to have their appendix out or their gallbladder out, and they had heart disease, and I was managing their diabetes, they went home, and I didn't get to continue following them. So I didn't want to be a hospitalist and only see people in the hospital. The second was, it was sick care. And I really do appreciate doing more than just sick care, just taking care of disease. I want to help people live their best life, optimize their health. And so a hospital setting is definitely kind of a sick care setting.
Yeah.
And so I didn't enjoy, I became good at it. I mean, that was my training, but it wasn't something that brought me the joy that I wanted to, that I felt outpatient care did.
That's interesting. Are you familiar with Peter Attea's work? So it reminds me of his book, Outlive, right?
Yeah.
Medicine 1.0, 2.0, and 3.0.
Yeah.
So it sounds like you were kind of stuck in that 2.0 world, and you wanted to dip your toe or go into that 3.0 world where you could help stop that from even happening to begin with.
Correct.
Like people being in that environment to begin with.
Yeah.
That's really cool. So what's wrong with the insurance companies?
Where do we start? I wish that insurance companies had more physicians who worked for them. I think that unfortunately, we physicians have given up the rights to really be business men and women, that we thought, we'll bring in businessmen and women to help us because we want to just heal. We want to treat. And I think it really did a disservice to us, because now if you look at healthcare, I shouldn't be having to talk to somebody who's never been to medical school for me to get something approved for my patient. And it happens every day where I'm trying to get something approved for a patient. The best example I can give you is one of my colleagues is a bariatric surgeon. She's very highly specialized in certain types of surgery. And she's literally on the phone with the medical director, who's an infectious disease doctor who's never stepped foot in an OR, and is telling her whether or not he is going to approve a procedure for a patient. He doesn't have the knowledge. So when they say you're talking to your peer, you might be talking to another physician, but it's not really, if you think about it, your direct peer, because for sure, I'm not going to tell her how to do surgery. I'm going to tell her how to manage the patient's high blood pressure and diabetes and everything else. But I can't tell her what instruments she's going to need, what's the best, procedure to do. Is it open or is it robotic? And so I feel like that's where some of the issues with insurance companies being in control have done a disservice to us. And I want to see physicians take the control back and be in charge of how to help our patients.
That's interesting. So what is the best way, in your opinion, for physicians to do that? Is it kind of moving toward what you're doing now?
Yeah.
Just getting ahead of this stuff?
Yeah. So if you're kind of listening to, you mentioned, Peter Attia, there's so many podcasts out there. And what we're trying to do is, one, educate our fellow colleagues, and two, educate the public so that the public can vote. The public can seek out and think, oh, I want that type of medicine. I didn't know I had those rights. And I love what direction you're going is, what are the things that we need to know that wasn't taught, right?
Yeah.
That's why I really like when you asked me, I was like, oh, I love this. This is because, you don't know until you know.
Yeah.
And if there are certain of us who are really trying to bring light to what's available, then the sky's the limit. I want our patients to know everything that is available to them, that they don't have to just seek what's approved by their insurance companies. Many of my patients, they will have their primary care doctor that's insurance-based, but then they come and see me for everything else. And then I can give them the knowledge they may need to go back to that primary care doctor and say, hey, may I have this done? Or I didn't know about this. And so there's twofold incredible opportunity there. One, that colleague that I may never get to talk to, that's their primary care physician, is learning something different. And two, it's empowering that patient that they are now a part of this, and they can, and if that, let's say that primary care physician is like, no, I don't think that's the best. Well, then they can know, like, okay, well, then I'm going to go seek other care elsewhere, because I know that this is available to me now, and I want the best healthcare.
Yeah. I have so many questions. So what would your advice be to somebody? Let's say that there's a listener out there, maybe in their early 30s, right? They're a high performer, executive or leader or something, and they want to get ahead of this stuff, but all they're being told, right, is that you need to go see a primary care physician. Here's the insurance. You got to find somebody in network, jump through all the hoops, do all that kind of stuff, and only see them when you're sick.
Yeah.
What would you say to that person?
I would say that's a great start. Get started there, and then start looking at some of these books and podcasts and know what else is out there. And so I'm hopefully being able to encourage them to say, like, oh my goodness, like, I can ask for an extended panel. Like, what are other things that I can have checked? There's more than just your typical total cholesterol, LDL, VLDL, and HDL, triglycerides. It's like, can I check, I have a heart disease in my family. Can I get an ApoB and a lipoprotein A and, an extended lipid panel? And, there's so much more. So start with the simple things, and then just continue to seek out practitioners that might be functional medicine trained or integrative medicine trained, those who talk about personalized medicine. And you can work with one of us right away if that's what you choose to do. And so that we can say, okay, you're in your 30s. Let's look at your family history. What are things that we should check now? Do you need an EKG now because you are an extreme athlete and you might be at risk for types of heart disease that no one else might pick up on? So that's where I think being in control of how you age is really important, and not waiting till you're 50 and you're having your first physical because someone made you do it,
Sure.
But being proactive. Those of us who are athletes, I'm not I work out. I'm not an athlete, but we're prone to other types of wear and tear, and we're hard on our bodies. So, looking at those types of, there are testing that we can do to prevent the wear and tear and see what's going on. So I think it's really important to meet with somebody who knows what to do next. If you ask me to go fix my car, and I wouldn't even tell you how to check if I have enough oil in there. I love that it's computerized and can tell me what to go do, but this is my forte. So I love when someone can come to me and say, okay, I'm 45 and my dad had heart disease. His first heart attack was, at 55. My grandmother had Alzheimer's, dementia, and just kind of give it. And I'm like, okay, what? And then I love to ask them, okay, what's your lifestyle? How much stress do you have? What's your nutrition like? If it's a female, how many children did you have? What was your menstrual cycle like? And so all that history starts organizing in my brain everything that I want to test them for and everything that they're at risk for. And I can put a plan together and say, this is how we are going to age. This is what I want to do to protect you from having the heart disease that your father had or the Alzheimer's that your grandmother had. So the sky's the limit with the preventative items that we can do by taking a good history.
Oh my gosh. Okay. So I hope we get a chance to get into all that. If not, we're going to have to, in order to keep this podcast episode not 8 hours long, might have to do a part 2 because I have so many questions. I want to kind of dive into, sort of something misleading around this obesity thing. But before we get into that, you've been named top doc for 7 years. Is that correct?
Yeah, 7 out of the 8 years.
7 out of 8 years, yeah. And that's for Phoenix. Is that in a specific category?
In obesity medicine.
In obesity medicine. So yeah. First off, congratulations.
Thank you.
It's a hell of an accomplishment.
Thank you.
Really cool that you live next door and that we can have this conversation. And when I read that, and I think I knew that, when we had talked about it before, but I want to kind of shine a light on that a little bit from a credibility factor, in case anyone out there is saying, well, why should I listen to her, right? Why should I be listening to this podcast? Well, you are credible.
Thank you.
Incredibly credible.
I'm hoping.
Yeah. No. And so, but around this obesity conversation, I need to understand this a little bit better. I actually have in my notes here, my second one was help me understand obesity and what it is. And I'm going to give you a little context here. In the past, I use functional medicine now, but in the past, I have relied on primary care, when I'm sick or something and all this. I have been told by 3 different doctors that I am obese. And this is wildly confusing to me because I look in the mirror and I'm like, I don't feel like I'm obese.
Right.
And this is an in-person episode, so maybe the listener can be the judge, but
you are not obese.
Help me understand why somebody in a professional medical field would label me as such.
Because they unfortunately are looking at one number, a BMI. And a BMI is great in that it is your body mass index is what it stands for. And it is on your typical 5'11", 6 foot white male. It doesn't take into account anything else, unfortunately. And so, and maybe there's a little factor that, if you're a female. And unfortunately, we are missing the mark with only looking at a BMI. So Josh, because I know you, I'm going to say your BMI is probably high because of the amount of muscle you have. And so they're missing the mark. So that's why those of us in functional medicine, specifically in obesity medicine, we have what's called a body composition scale. And a body composition scale is going to tell me what your bone mass, your fat mass, your muscle mass, your total body water.
Is that the same thing as like a DEXA scale?
So DEXAs can do that. InBody is a brand. Tanita is a brand. There's ones that you literally will dunk yourself in water. Who wants to do that every time they weigh in? That's how a lot of the research is done using one of those. But there's one that looks like an egg. It's a pod that you sit in to do it. So, but the easiest way is a body composition, like an impedance scale. So it sends a little electric current through your feet. You have to be barefoot, and that currency, how it goes through muscle and bone and fat and water, it'll give us numbers. And so that's a better way of us seeing whether or not someone is truly overweight or obese. And why we like that, I'm going to take it a step further, is someone can have a normal BMI and their fat percent can be in the obese range. And we call that normal weight obesity. And so many people would be missing the mark because, unlike your story where they're saying you're in the obese range, this person is saying, oh, your BMI is fine, but they're actually metabolically obese. That's more dangerous. And so I'd be interested in knowing what your fat percent is on a body comp scale, because I have a feeling, knowing you're probably under 10% body fat.
No, certainly not under 10%. No, I think the last time I checked, because I do have one of those scales. I don't know how accurate it is. I think it's called UFE or UFI. I don't remember. But I think I'm around 17 to 18% on a good day. That's what it says.
I'm going to challenge you to come to my office. I know you're less than 17%.
Oh, cool. Well, hey, you know what? That makes me feel great. You're already my favorite guest. No, I appreciate that. I've got questions around this obesity conversation, especially in this day and age, and I'm curious. I hear narratives, and I don't have enough knowledge to fact check this stuff or understand what's true and what's not, but how a lot of obesity is genetics. A lot of it is, the maybe stress factors, I think, come into play. Some of it is obviously some of us not taking care of ourselves, probably not eating properly, nutrition. What do you most often see when somebody comes in and they want to lose weight? Is it lifestyle? Is it genetics? Is it, we hear this thyroid function. Yeah. I don't know I don't understand it. So help me understand.
It's definitely multifactorial.
Okay.
And the worst thing that you can tell somebody is eat less and exercise more. So I love the stance of the Obesity Medicine Association talking about, if you do not understand the disease and do not know how to treat obesity, please refer, because there's such a stigma. And I've been in the weight loss world since 2008, and I've seen the change tremendously. And back in 2008, I prepared so many people for bariatric surgery, and it overall did help patients. I think why we were more successful is, one, I had 6 months to work with them and really try to figure out why the weight came on, so that once they had their surgery, I was helping them with keeping their weight off. But in this day and age, so many people are quick fix, and they don't want to fix something, and they'll choose something else to do as their habit. Let's say it might not be eating, it might go to drinking or drinking their calories. But obesity is definitely multifactorial. I think what we've done to, if I can elaborate,
Please.
What we've done to our food is definitely been a disservice. We have more sugar added to things that shouldn't have sugar in it. My favorite example is peanut butter. Peanut butter should be salt and peanuts. And that's it. It should have 5 ingredients in there. One of them being sugar. My husband might argue with that, but we like to joke with who has the better peanut butter. But so our food is less calorically dense. and it doesn't have the same nutritional value. We are more sedentary, so we're definitely not running around. I had recess growing up. Like, it was an hour. We had PE. It didn't matter if you liked it or you played a sport. If you played sports, you still had PE, and then you had to go play your sport. You know,
is that not happening today?
No, there are some schools that don't even have PE. They don't have the money for it, and they're trying to fit in something else. So I think the lack of nutrition, the lack of exercise definitely play a factor. Genetics do play a factor. You are more likely to have trouble losing weight if both of your parents were overweight when you were conceived. So a lot of times when I do a lot of preconception medicine, when I talk about the best thing that you could do is be fit before you get pregnant. And that's both for female and male.
Interesting.
Yeah. So I talk a lot about that. And then stress. Stress will put on so much weight. And we have a lot of endocrine disruptors now with plastics and things. So I think there's a lot more hormonal disruptions that can lead to obesity. And then that as we enter into perimenopause and menopause, and I like to call it manopause, weight definitely can come on. And so it's a multifactorial disease.
Wow. Okay. So that helps me understand a little bit more the diversity in which, this can occur, and all the different factors that can lead to it. Is there one or another that dominates what you see, or are they all kind of an equal?
I think it's definitely equal, but lifestyle is key.
Okay.
Really,
but it's not as easy as eat less, exercise more, or caloric deficit, because you hear this stuff, and this is why I'm challenging it, right? Is that you hear this stuff everywhere on podcasts and social media is just caloric deficit. You want to lose weight, that's what you do. And that's the prescription in today's world. But to your point, right? It's like a quick fix, kind of thing. Yeah. But you're saying that's not.
It's not the whole picture. Yeah. Caloric deficit's definitely part of the picture, but it's not the whole picture. And I like to challenge it and say, what are your calories? Because you can have 500 calories of carbohydrates or you can have 500 calories of protein. They're both totally metabolically different. And so when someone says caloric deficit, I really want to challenge them on, okay, what are you eating? What are you reducing? And so that's really key. And we talk about nutrition a lot in my practice. So I want to know what my patients are eating. Yeah.
So help me understand this. So let's talk a little bit about the differences between calories, carbohydrates, proteins, refined sugars. What is good? What's bad? What kind of ratios should people be shooting for? Obviously, I shouldn't say obviously. I'm assuming that can vary from person to person. But is there like a baseline, like a framework?
Yeah, I think the easiest it's kind of like you're almost like the question that people ask is like, what's your favorite diet or meal plan? And I like to tell people like the one that you're going to stick to.
Yeah.
And really focusing on whole foods, not processed foods. So if you can stay on the perimeters of a grocery store, that's where your meats are and your vegetables and your fruits. There's nothing usually processed on the outskirts, of a grocery store. The middle has all the processed items. And I grew up in that Mediterranean diet. It's probably one of my favorites, and it's because it's based on whole foods. Lots of fish and vegetables and the rainbow of vegetables and fruits. And if someone is focusing on the amount of protein they're eating, there's usually no room for them to then overeat their other items too. And so a lot of people want me to say, well, what's the percentage? Is it 50% this, 40% this? And I'm like, we can get into those specifics once we get you to just overall eating your a good meal plan. Like just if you can focus right now on protein, I usually tell people about 1 to 1.5 grams of protein per kilogram body weight. That's a great place to start. And so let's say, we'll make it easy. Someone is, let's say they need to get 75 grams of protein in a day. So let's say 3 meals at 25 grams of protein. If they can focus there, that's kind of easy to do. They don't feel like they're counting calories or how much.
That's a decision, right?
Right.
I'm going to have a chicken breast, or I'm going to have a cut of fish.
Yep.
Or something like that,
Yep.
right? So that's what makes it easier.
It makes it easier. And then it's like, okay, do I want to add it to a salad, or do I want a vegetable on the side? And I'll have a piece of fruit as my, as my dessert. If I can get them to kind of start there, it's amazing how they will start feeling better, because they're not going to be spiking their blood sugars. They're not eating a lot of refined items that may, again, spike their blood sugar, or have them not feeling very well, or feeling like they're hungry again within an hour. And so I'll actually put a glucose monitor on my patients so that they can see what food is doing to them. I love doing that because, one, I'm jumping a subject, but one is my females who love their glass of wine at night. I love to see what it does to them. And I'll put their Oura ring on, or sleep monitor. 2 is I want someone to eat go to a Mexican restaurant and have the chips and salsa first. Mm-hmm. And then have their meal. And then the next time, eat their meal and then have their chips and salsa, and just prove to them what's happening to their blood sugar and the order in which they eat their food.
What is happening to them?
So if you start with a chip, it is spiking your blood sugar because it is refined. It is corn or flour and that chip, and it is in its simplest form, and your stomach is empty. And so that blood sugar is spiking because it didn't have to take the time. There's hardly any fiber, in a corn chip or a tortilla chip. And so your blood sugar spikes, your insulin follows because it says, oh my gosh, that blood sugar is high. And so with those spikes, it's going to bottom you out, but you're full for a while with everything. So by the time they bring out your burrito or your carne asada or something, you're looking at your plate and going, oh, I'll take a few bites and I'll take the rest home. And then an hour later, you're home and you're opening up your to-go box and you're eating the rest, and you're like, how I had to roll myself out of there. And especially if you had a margarita on top of it, it's just your body went, oh my gosh, I just had an extreme blood sugar rush. My insulin at least kicked in and brought it all down, but now I'm starving because I didn't get enough sustenance in there. And so wearing a glucose monitor can prove what's happening inside that body. And you might even notice a few foods that made you when you eat it, it's healthy for you, or it might be a healthier option, but you feel horrible. And when you see what happens to your blood sugar, that might be like, oh my gosh, I just have that piece of information. My body doesn't digest this. It reacts to this. I shouldn't include this in my diet.
So can you explain to me, I'm a 12-year-old?
Yeah.
The role of blood sugar and glucose in the body and why that's important.
Yeah, so glucose is not evil. I love that you're asking me to kind of, go down to the basic like that. So this is what I would tell my kids is, food isn't necessarily good or bad. It can just be, is it nutrition? Is it nutritious? Is it helping you build your muscles? Is it helping you with your energy? Because you do need complex carbohydrates. You can use some of this. So glucose is a molecule that is very helpful for your body to create energy. It's the simplest form of fuel. We can kind of talk about it that way. And so what complex carbs are is just the bonds are all together. It's that glucose molecule. There might be fructose or other types of sugars in there, but it's a harder molecule and larger. And there's fiber. When we say complex, there's usually fiber attached to it. So if you kind of think of your a broccoli, there is some carbs in there, but you're not going to get a sugar spike because there's so much fiber in that. And so glucose is that molecule that we need. We can't live without glucose. But the reason why people who are on a carnivore or a keto type diet is we can make glucose out of, we can break down other molecules in order to make a glucose molecule. But most people just know it as it's your carbohydrate. It's coming from your sugars. So that's your starches. So many people think like, oh, I don't eat candy and ice cream and cookies and cakes. And I'm like, well, are you eating potatoes and corn and your rice? So that yes, you are getting starches. Then in a different, you're getting carbohydrates in a different form. Your bread, those are forms of carbohydrates as well.
Okay, so let's talk a little bit about if somebody wanted to make a change and they wanted to lose weight or have a lower body fat composition. There's solutions that I, as a layperson, not in the medical field, I'm aware of, but would love to know more. The first one I'm going to ask is, the craze that's been going around Ozempic.
Yeah.
Right? So you probably knew that was coming.
I knew it.
But,
I was waiting.
Yeah. So and I try to do as much research as possible. Like I have listened to podcasts on this. I've read about this, and I've read about how science itself is at odds. Like there's doctors that think that it's great. There's doctors that swear it off entirely, and that there's very little understanding. I shouldn't say very little. I don't know, but there's a lack of understanding at some point of what it actually does and like how it works. This is kind of some of the stuff that I've found. So, what's your opinion on that? And is there a place for it? If so, when? Let's debunk around this. What's it called? GLP-1. So let's unveil this and peel back the layers of the onion here.
Yeah. So I am going to just tell you straight up, I love GLP-1s. And it's like, cousin of GLP, GIP, which is 2 peptides. And then there's a 3 peptide coming out hopefully next year. Why I love these so much is they've been, so first off, these types of medications have been around for over 10 years, the GLP-1s. The first generations just didn't work very well, and they were for diabetes. About 6 or 7 years ago, the second generation came out, the first one being what everybody knows as Ozempic. So they noticed as Ozempic came out that weight loss was happening and there were other benefits that were happening. And so the pharmaceutical company said, okay, well, we want to do a weight loss study. And they did, and they named it Wegovy. So the main compound is semaglutide or semaglutide, depending, potato. And so
I don't remember anyway.
And so I would say most people just kind of know it as Ozempic because it was branded first. And so we every single cell in our body has a GLP-1 receptor. And so its main function is glucose homeostasis, keeping your blood sugar stable. So it's kind of giving your brain feedback of whether or not you're hungry. It's giving your liver feedback of whether or not it needs to release glucagon that then increases your glucose, or what's the insulin sensitivity happening. It is released from our L cells in our gut naturally. We just, if we don't know why some people are not producing it as much as they should be, but that's our satiety hormone that we naturally already produce. So this peptide that we're injecting is taking orally, is replacing and increasing the GLP-1 production or replacing it in our body. And that's why we're starting to see the satiety, and we're seeing weight loss because most of us aren't eating as much when we're on this. Why we love it in functional medicine is we're using subtherapeutic doses or microdosing. So I kind of want to really define this. When people say they're microdosing, what we are truly doing is using lower doses than the first dose available. So like Ozempic, it's supposed to start at 0.25 milligrams. Microdosing is doing less than that. And so so a little bit of that can really help those patients who have a lot of inflammation. We're seeing that. There's the great study was 10 years ago with one of the original ones showing how it was reducing inflammatory markers. So a lot of our patients, even if they're not losing a lot of weight, they're going to say they're less puffy. Their joints aren't hurting as much. They feel like their brain fog has reduced. And I truly believe it's because of controlling the glucose issue, the imbalance, and you're bringing it more into a balance here. Our brains don't want to be overloaded with glucose. That's what we call type 3 diabetes is also, and it's almost like a dementia of the brain, but it's from the blood sugar being high for so many years. And so, I think I'm running around this, and I apologize. It's just there's so much to talk about with GLP-1s. So they did start off as a diabetic medication, and now we're seeing all of the benefits. So in the past 2 years, they've been approved for sleep apnea, for cardiovascular risk reduction, for people who have what the old term is called non-alcoholic fatty liver disease. And so we're seeing the benefits of using these medications for more than just diabetes and weight loss. And I think it stems from we're not releasing as much of this from our guts. Our GI systems are not as healthy as they once were. And so that's why these medications are a game changer, is because it's replacing something that we're not naturally producing to a higher degree.
Is that a result of some of the food quality issues?
I think so.
That you mentioned? So help me understand the risks. Some of the things that I've heard are when you stop taking it, your satiety will go back to normal, and then you'll overeat. I've heard that and this is all hearsay. This is why you're here. Yeah. So I can ask you this stuff. I've heard that it disrupts the reward center in your brain, and so you won't get as much satisfaction from other activities as well. So what are some of the risks or things that people need to be aware of?
So I think those are great points. And one is when you work with someone who really understands the power of the medications, I feel like I do not see as many side effects as other practices see. One is I'm making sure that we use the lowest therapeutic dose. When you use the lowest therapeutic dose, you're allowing for there to still be enjoyment in food, and still have what I like to call appropriate hunger, instead of having no hunger now and having to force yourself to eat, right? That's not healthy. So I love talking about appropriate hunger. So I will ask my patients, are you able to get your meals in? What are your meals consisting of? Are you enjoying food? Because if their answer is no, I need to dose it down. We're on too much of a dose. Another is, and that's why I don't love the term Ozempic face, because truly, if you are losing weight correctly, you're not going to look, what I say, cachectic, or like when people say, someone asked me if I had cancer, all I did was lose weight, And unfortunately, with the availability of these medications and not being monitored like they should, we're seeing the side effects where there's muscle wasting or sarcopenia that we're seeing. And it's because nobody's asking them, what are they? They're just getting their medication and we're not following their blood work. We're not asking them, are you exercising? Are you getting your protein intake in? So someone is going to look like they're thinner, but when we look at their body composition, they're losing muscle and fat. And so they're really not healthy. And so if you're using these medications correctly, you may lose a little bit of muscle, because let's think about it. When you lose 100 pounds, you're not going to need all the muscle that your body had initially as well to carry around 100 more pounds. But the severity of that line of how much muscle you lose is lessened when you are exercising and eating protein while losing weight. We can change the degree of decline. And so the gastroparesis is what I hear a lot. That's the slowing down of your gut. And so that's why a lot of patients will talk about, or you might hear about people with constipation and things. And so we have to reverse that. There are things, so staying hydrated, maybe increasing magnesium, increasing your fiber intake, not going up to the maximum dose right away. So we can ward off a lot of side effects by using the medication properly.
Wow. Okay. So I'll ask you a quick question. So in your opinion, you said working with somebody qualified to understand and administer this medication, how many practices out there are maybe not qualified to administer this? Because maybe this is where a lot, it has to be, this is where a lot of these ill-noted side effects are coming from, or people, prescribing this stuff, but not really understanding the entire function of it.
Right.
So what are some questions that some people can ask either their primary care doctor or somebody who they're asking about this medication to ensure that it's coming from someone qualified?
Yeah, I would ask, are you Obesity Medicine certified? Are you someone who is going to be following my blood work as I lose weight? What nutrition plan should I be on while I'm on this medication? What is your game plan for me as I lose weight? Will you help me wean off this medication or microdose it? Those are all, where are you getting this medication from? Those are really big, because I've been very vocal in this space over the last few years because I want people to understand there's a right way and a wrong way. And I don't want the FDA to take away these medications because they've done so well for so many people. It's been an answer for them. So I'm very protective of how it's being used. So if you are doing a telehealth visit with someone who has no clue how to help you truly lose weight and just giving you the medication, run.
Okay.
That's how I'm going to say it. It's just run. The other thing too is these A-frames that are outside of salons, or even there was one outside of our UPS store. They're like, get your Semaglutide here. I'm like, who are they seeing? They're not even seeing a physician, and you can just go in and buy it. Just run, please. Don't even buy it. I've had patients have what's called cellulitis, or an infection of the skin, because it was compromised. The vial was compromised. So they told me they got it from someone who got it from someone. I'm like, why would you inject yourself with something you have no clue where it's from? So I've been very protective. If you are getting it from either the drug company itself or a approved compounding pharmacy, you are not going to see the same issues as what has been out there. So
okay, thank you, and I hope my audience is listening to that.
I hope so too.
All right, so help me understand. Then we talked about the Ozempic, and what about fasting? Where is that something that you use in your practice for people? And when would you use something like that over something like Ozempic or another tool that you have? I want to understand a little more about fasting.
I think fasting is great for a majority of people, and we may even use it with those who are on a weight loss medication. And so fasting, the science behind fasting is when you go a period of time without food, you're allowing for autophagy. You listen to Dr. Attia, right? You're allowing for autophagy to happen. And
fascinating.
That's the cleanup of cells. And that's actually happening when you can have restorative sleep. So I'm going to just talk about, I actually like talking about timed restricted eating a little bit more than fasting. And I think my bias there is because I see so many perimenopausal and menopausal women. Fasting is not actually beneficial to them, but timed restricted eating is. And so what I will usually say is I want us to have a window of time where we eat, and then there's a window of time where we are not eating. And so it's a little bit less restrictive kind of feeling than saying you're going to fast till noon, you're going to eat till 6, and that's kind of it. And so sometimes especially when you're using these weight loss medications, I need need maybe an 8-hour window to get all of their calories in. So I like using timed restricted eating as a definition for them to do. But in essence, I'm still having a time period where they're not eating and they're letting autophagy happen inside of their body.
How long does it take for autophagy to happen? How long do you have to not eat for, or is that not the right question?
You know what? It's a great question. And I think depending on the literature and who you are speaking with, it's different. So I usually like to have a minimum of 10 to 12 hours of not eating. If we can have, at least that, I know there's benefits that are happening. It's someone who wakes up and is eating at 6 a.m. and then doesn't eat till 10 o'clock and then goes to bed, right? That's just not healthy. Mm-hmm. And so if we can stop eating at least 2 to 3 hours before we go to bed, that's optimal, even up to 4 hours before we go to bed. And if you could throw in a walk after dinner, that totally changes your metabolism too and helps with, there's so many benefits to having a walk after dinner, not only just stimulating your muscles to uptake that glucose in the meal, but it's going to help you with sleep and everything else. So I really encourage those to just take a quick walk after dinner.
That's interesting. When I stopped eating, I think it was about 3 hours before I go to sleep, I noticed, because I wear the Whoop,
yep.
right? And so, I've been wearing that now every day since, 2021, something like that. It's crazy. But it's really helped me understand my body a little bit more. I haven't yet worn a CGM, which I'm looking at, like the levels and stuff like that, but that's a whole side conversation. Yeah. My point in that is that once I stopped eating, well before I went to sleep, I noticed a spike in my HRV at night, which is wild. I have low HRV to begin with. It's just the way my body works, I guess, and maybe we can talk a little bit about that too. But if I didn't eat, I would have more deep sleep, more restful sleep, and my HRV would be higher at night. And it was such a simple change. So it just kind of speaks exactly to what it is that you're saying. Today's episode is sponsored by OneAccord. They're the experts in helping business owners prepare for transition, succession, or exit. Guys, here's the truth. Most business owners wait way too long. They know they should build stronger leadership teams, document processes, clean up the financial reporting, all the things that we talk about on this show, but they stay stuck in the day-to-day operations and the business just never truly becomes transferable. OneAccord's Oasis system, though, changes all that. It's a proven framework that helps you create alignment across your team, build disciplined execution habits, which is huge, and increase company value, which is the entire point. So when you do decide to transition, you're not scrambling. You're ready. Buyers notice the difference. Trust me, multiples increase, and you, the owner, get the transition on your own terms. Everything they don't tell you, listeners, get access to a complimentary value readiness snapshot. It's a short assessment that highlights your strengths, your risks, and the hidden opportunities to grow enterprise value for your own company. Start your value readiness snapshot at oneaccord.co/oasis. That's OASYS /Josh Zolin. Again, that's oneaccord.co/oasis, OASYS /Josh Zolin. That's me, for your exclusive podcast offer. Back to the show. I want to understand what really happens during autophagy. Like what, very topically, cellular repair, but what other benefits does cellular repair have on the body?
Oh, so many things. So that's really, when you have cellular repair, you're getting rid of cells that are sick. And that's really key. So, at any point in time, we all have, let's say, non-functioning cells, cancer cells in our body, but we're able to clean them up. They're not unmatched. We can control, their growth or their dysfunction, so that we're decreasing disease. And so our true cell, our powerhouse, our mitochondria really need autophagy to happen. And we want them to multiply so we can also make more ATP, but we don't want mitochondria that are not functioning. That's not good either. one of the key things I like to talk about is oxidative stress, which is that resting of our cells. And so you need a little bit of oxidative stress. A little bit of stress helps you. Think about when you're, in the gym, you need a little bit, but we don't want it unmatched, and we don't want it to go on, and we don't want to be at the point where we can't repair. And so that's where it's really important to have a good night's sleep every night to allow for restoration and cleanup of the cell. You want it to put out the fire to reduce the oxidative stress in each of those cells so that the function is ready to go in the morning, or, every second. Like, our bodies never stop until we die, and so we do, but there are times where we're awake and we're not awake, and we want to be able to recover. Recovery is really important. Yeah. And if we go on to get into the minutia, there's interleukins, there's cytokines, there's all of these. And so you do want them to be, NF-kappa B, your tumor necrosis factor, like that gets really into the weeds, but you want these levels to be controlled, because when they're unmatched, that's when autoimmunity happens also. So I know I mentioned cancer, but then there's autoimmunity. So there's Hashimoto's and mast cell activation, and, we get into a mess, and that's when the body can't put out the fire. Mm-hmm. And so depending on your genetics, that fire starts to hurt the cell, that hurts the tissue, hurts the organ, and now your whole body. And so we're trying to always unravel it back to just that cellular, that cell. What can we do, to help the cell function like it's supposed to? And so it's protective as we age.
It's like drinking from a fire hose. I'm learning a lot. No, this is fantastic. It reminds me of have you read the book Why We Sleep by Matthew Walker?
Actually, I have not on that one.
Changed my life.
Okay, I think maybe because I sleep so well, I didn't.
No need, then, right?
Yeah.
It's a fascinating book, and I think just kind of having this conversation, you'd probably really enjoy it. The science behind sleep, I'm sure you understand a whole lot better than I do. But after reading that book, like after I came to terms with the damage I've done to my body over the years from lack of sleep, because I was for a long time your prototypical just go workaholic. I would go to sleep at midnight. I'd wake up at 4:00 in the morning, and I would do it all over again. Yeah. Did that for years. And so I finally started extending the amount of time that I sleep. And then I read that book, and I was like, I'm really messed it all up.
But the beautiful part is neuroplasticity. Hopefully he has that in the book. So you can reverse so much damage. Yeah. So the way you live now can make up for lost time back then.
That's, I sure hope so. I think a lot of us out there probably hope that. Okay, that's really cool. So let's move into, I'm getting curious about, you mentioned a couple times, perimenopause, menopause. What percentage of your patients are women versus men?
I think about 70% are women and 30% are men right now in our practice.
Okay. And so, I was trying to figure out when I was going to bring this up throughout the episode, because, we talk about, obesity, we talk about weight loss, we talk about all this kind of stuff, autophagy. And I'm wondering in every conversation we have, what are the differences between how men process this stuff and how women process this stuff, right? And is there a difference, number one? And what is the difference, number two? And we'll answer these in succession, so don't answer them right now. But as a woman goes into perimenopause and then into menopause, how does that change the conversation? So let's start, I guess, with that one. When does it happen? What happens to the body? And what can women do in the wake of what's happening?
Yeah, I think it's a great question. I love that so much more information is out there now. We used to think that perimenopause was literally maybe just a year or two before menopause, and there was nothing that we could do. And now we understand that perimenopause can be for 10 to 15 years, can start in your 30s. We used to think that you have to be older than 45, because the typical average female goes into menopause between 51 and 53. if we go back to our lifestyles and what's happening, I feel the shift is we're seeing menopause even earlier than before. We're seeing longer perimenopause. And I think it has to do with, the whole reason of why we talked about there's more obesity right now. We're just not fully taking care of ourselves. And there's more use of birth control or not having children. All of those I think are huge factors into this, and endocrine disruptors. And so, but if I were to get back onto the topic of just perimenopause and menopause, these shifts are really important for us to understand. And I'm of the generation of, I literally finished medical school like so many people. And the WHI, the Women's Health Initiative, came out in 2002 and scared the bejeebus out of all of us, where we stopped prescribing hormones, and women literally dumped their hormones into toilets and stopped them.
Help me understand that. Let's talk about that for a second. What did the WHI come out with and say, and why did that occur?
The WHI, the Women's Health Initiative, came out and said by doing hormones, you had an increased risk of breast cancer. And for any female, that is their biggest fear, is breast cancer. Despite the number one cause of death being heart disease, not even breast cancer, women are most afraid of breast cancer. And unfortunately, there were so many flaws of this study, but all the media promoted was that hormones caused breast cancer. And so literally stop.
So that was the headline.
That was the headline.
And when you say hormones, are you talking about estrogen, testosterone?
I'm talking about, so these women were on a form of a synthetic progesterone. So it wasn't even true progesterone, micronized progesterone that our body naturally has. And it was synthetic estrogen. So it was like Premarin and Prempro specifically progestin. And the number of increase was just one case of breast cancer. So it wasn't even like statistically significant increase. These women that were in the study were after menopause, so it wasn't even the perfect candidate to see whether or not hormone therapy was going to help them. Majority of them were overweight or obese. They had smokers in the group. It just wasn't a great study for us to talk about the perimenopause and menopausal female.
And this came from the
WHI, the Women's Health Initiative.
I don't want to derail you, but I have questions around this real quick. I want to make sure I get out. Is that all right?
Yeah. No, that you can shoot them out, and then I can.
Okay.
I can answer.
Why wasn't that study done in a way that was conducive to getting the proper information?
Yeah. I think now we can look at it, 15, 20 years later, and we have some information where the researchers have said, oh my gosh, no, there is safety, because they continued the women on just the estrogen arm, and they were shown to have protection. So at least, so I love, like right now, more is coming out where we're diving into it, what went wrong, what went right, so we can look through that, and we truly, I just touched the mic.
That's okay.
Sorry. We truly understand that it was the synthetic progesterone called progestin. And so there's many. I love when we can see, what did we learn? What can we take from this? So at least we know that there is safety in using estrogen. It's different than what's in birth control. We're talking about true estradiol, and we know the safety of progesterone, and we know that progestin is not great to use, especially in a menopausal female. So there's many things that have come out of that. I think that my favorite book, if you want to dive into the weeds, is Estrogen Matters. It's a breast oncologist, Dr. Dr. Blooming. I am not the best at names at times. And he has an Instagram now, which I love it because it makes it easier for women to get the right information. But he dives into this, and his book goes through all of the studies over the past 30, 40, 50, 60 years and includes studies from Europe, and just really dives into the safety and efficacy and the need for us to use estrogen and support our females during this time. Because as I mentioned a few minutes ago, heart disease is the number one killer. And when do women have an increased risk? After menopause. That's when their estrogen drops. And so if we can help women transition and even support them, we are going to reduce heart attacks and dementia and bone fractures, and just the quality of life. So many women were told to it's a rite of passage, and, your hot flashes are a rite of passage. Don't complain about it, and now we understand the more severe hot flashes you have, the more at risk for health disease you have. It's not a rite of passage. Let's treat you. Let's figure out the best way to control these vasomotor symptoms. And it's more than just hot flashes and mood swings. I'm like, how far deep do we want to go? I'm just very protective of hormones because I want women to slow down the aging process. I don't want them to have osteoporosis. I don't want them to have dementia. I do not want them to have heart disease. And I want them to keep their weight healthy too, their muscles healthy. We need testosterone. Our ovaries and our adrenal glands make testosterone. So when a female goes, that's a male hormone, I'm like, it's a sex hormone. It is not a male or female hormone. We need testosterone too. We need muscle too, and our executive function. So a lot of women will be like, I'm divorced or I'm a widow. It doesn't matter if I have a libido. And I'm like, it's testosterone's more than just that. It's our executive function hormone. It's one of the main ones that help us concentrate and have a conversation. And so anyway.
Wow. Okay. So I want to talk to my audience now that are in relationships, right? So I'll ask this question. You said that perimenopause can happen up to 10 to 15 years before menopause.
Yes.
What does this look like for a woman, and how would she know if that's what's happening? And then how can her spouse or partner notice and support her through that as well? Because listen, I'm a kind of your prototypical ignorant male with this kind of stuff, and I don't understand it fully. I'm trying to understand it, but mood swings, hot flashes, stuff like that, to us who are less informed about what's actually going on, and maybe even kind of to your point, women think that this is a rite of passage and it's just something they have to go through. I feel like that can be at odds.
Yeah.
And if we don't have the conversation of how to communicate that properly inside of a relationship, it could cause more damage than it has to. So can we have a conversation around that?
Yeah, I think it's great. So hot flashes might not start immediately. The biggest thing is women know their cycle very well, typically. And now there are so many wearables where you can kind of keep track of even your cycle. So the cycle starts to become a little bit irregular, whether it's more days of their cycle, the days between their cycle might decrease or increase. They might skip a month. They might say, well, usually my cycle only lasts 3 days. Now it's 7 days. And then it came 14 days later instead of 28 days later. So there starts to be a little bit of inconsistency with their cycle. Their PMS is not just during that time either. And they are noticing that they are moody all the time. And instead of just being a little bit of moodiness where they can control it, it's a little bit off the charts now. Brain fog is big. I will tell you, me personally, mine was I couldn't do my workouts. I was so frustrated that I had an IUD and then I had an ablation. So I'm going to speak to those women. You don't even know if you're ovulating or not because you've had or you're on continuous birth control, but you just know something is different. Mm-hmm. And that might be the brain fog. I started to have brain fog. I couldn't work out the same. I was, in a gym and noticing I couldn't hold my plank as long, or I was going down on my weights and I'm thinking, geez, I'm only mid-40s. It can't be perimenopause, and it was. It can be a decrease in the libido. It can be vaginal dryness. There's so many other symptoms other than just being moody, crying, and having hot flashes. So I think most women know something is going on. They're starting to put belly fat on where they've never had any belly fat, and they're just not feeling like their self. I would encourage them to get their hormones checked, and check and see what is going on. And it's not just an LH and an FSH. So many women only get those numbers. It's looking at your progesterone. It's looking at your testosterone. It's looking at your free testosterone, your estradiol level. So seeing somebody who understands your hormones is going to be imperative here. So we know which ones to get to look at your thyroid, because the thyroid is more likely to not, it's one of those hormones. It's part of your, we like to call it our endocrine axis. When one is off, another one might be off. The thyroid might need to be supported. Might not need to say that you have hypothyroid now, but your thyroid might be suboptimal because your other hormones are suboptimal. So supporting the thyroid can also help there. So I hope that kind of is just kind of the tip of the iceberg that you're kind of understanding.
Yeah, absolutely. So I would say then, what can somebody's partner do? What can our husband do? How should they respond to this?
Yeah, I would say it depends on how good of a connection you have with your partner, right?
Fair.
If you don't have a great relationship where it's like you can give positive and negative and have true conversations, you coming up to her and saying, "Hey, go get your hormones checked." I think
probably derail pretty quick. I would imagine for some
most likely.
Okay.
But if you have a great relationship, you can say like, "Babe, let's monitor your cycle. I think I'm noticing these things. What are you noticing? What are you feeling? What are some of the things that I can support you with?" And I love in this day and age with TikTok and everything, there are so many now funny little reels on this subject that I think it's making it even easier to kind of just, send that reel to your significant other and say "I think this is you. Let's laugh." Or the nicest thing to do is say, "Hey, when was your last well woman's check? Are you due?" And kind of just caring about them. Let's go see, if you have any hormones that are off.
So let's speak to maybe some of the listeners. We have our listener demographic right now is mostly male, right? But I do have some women who listen to the show too, and most of the listeners are high performers, executives, leaders, people who tend to sometimes disregard the hard things in personal life just to make sure that they're succeeding professionally, I guess is the best way to put it. What would you say to a woman who's going through menopause or perimenopause and she's just kind of trying to suppress it, just get past it, get over it? I mean, what's the ideal outcome? I know not ignoring it, right? But is it hormone replacement? Is it specific exercises? What can they do to actually treat the root cause of this?
I love that question. And I'm going to even add it to, since you have more males listening to, the importance of them taking care of themselves too. So first off, high functioning, powerful women, thank you for being badasses. And one is, a lot of us might have had our children later or chose not to because of being CEOs and being high performing females. So the way that we have aged have been different, and you might still be on birth control and not knowing what's going on. I would encourage you to go off of it and see what's going on and get your hormones tested, because the way we treat menopause is not through birth control. And so I'm going to encourage them to seek out medical, testing and advice and figuring out what's going on. But we're going to go to the root of how can we reduce your stress? And you might have to change how you exercise. So boot camps and, HIIT type exercises are not going to be optimal during this transition. It can actually be more stressful to you. And you might already be noticing it, that you are pooped and exhausted after a type of exercise instead of being invigorated like you were in the past. That was my story. I had an acupuncturist who told me, Melody, you cannot exercise like this right now, not until your hormones are balanced again. I'm going to encourage you to do yoga and Pilates. And that meditation time and that stretching time did change because my body wasn't functioning like it used to function. And I was more apt to having an injury. And these women might be noticing it right now, where they are injuring themselves by going to their boot camp. Or they're more sore, they're not recovering. So I'm going to encourage them to, one, incorporate stress relief. That might be meditative breathing, going to sleep an hour earlier, making sure their nutrition on par. If you're an executive, get a meal plan, get a personal chef. Do not go through the drive-through. Please spend some money on you and do a meal prep service just to keep one thing off of your plate of doing, grocery shopping and fixing meals then. And so I think those are really important for them. And then talk to someone. If you are a high risk and you don't want to go on to, hormone replacement, there are a lot of things that we can do. And it's amazing how a little bit of weight loss, a little bit of sleep, a little bit less stressful exercise, your hormone levels might go up. So it's not always where you have to replace them right away. And I'm going to flip it now to our, you've got these, you have men who are very good in their business and everything. They might be noticing that their testosterone, there's a reason we call it a beer belly and it's non-functioning. They'll have an increased amount of estrogen in there, and their testosterone might be low. So again, I will talk to those men specifically. Start cleaning up your diet. Start exercising differently. Start getting a little bit more sleep. Take things off of your plate, and let's see whether or not your testosterone goes up on its own. If it doesn't, let's talk about testosterone replacement. And you don't necessarily have to have a ton of testosterone on board to feel it and to feel like your executive function, your endurance is back. It's not just libido. It's an incredible hormone for so much more than just our sex lives. Yeah. And so I love when I can help get one of my men healthy again, where they're naturally producing more testosterone, and we didn't even have to, go to replacement therapy just yet. And that they can notice that, oh my gosh, I did something for my health. Like my body responded. Yeah. It's empowering to see that.
Absolutely. I'm glad that we kind of took it there. So let's shift to men's health for a minute and kind of unravel this hormone testosterone conversation. I have heard that over the years, the normal range of testosterone has been declining. How much truth is there to that? Why? And is it a problem?
Yes, yes, and yes.
Okay.
I think it goes along with 2/3 of America is obese and overweight. And with that, you're going to have lower sex hormones. Your testosterone is going to be lower. Your estrogen is going to be higher. And so we have to get to the root of that. Why have we put the weight on? And a lot of it is a sedentary lifestyle and poor food, lack of nutrition, and then comes along poor sleep. You're not allowing recovery to happen. And I see a lot of sleep apnea. Sleep apnea that is not treated is a loaded gun, in my opinion. We really, 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 even if you're tall and you don't snore, if you're not waking up rested, we need to look at this. When a wife says you are snoring or, oh my gosh, I thought you stopped breathing. We have to figure this out. And so, because when you think about it, you're stealing oxygen from your vital organs when you stop breathing. And so a sleep test is imperative, in my opinion. And I love to tell my patients is, if you do have sleep apnea and we get the weight off, you may not have sleep apnea anymore. But sleep apnea is not always in someone who's overweight or obese. I've had very skinny patients who still have sleep apnea, and we know that it's their anatomy. They just they close off, and so a CPAP machine or a mouth guard. There's an Inspire mechanism where it forces the tongue forward and keeps the airway open. So lots of ways of treating sleep apnea, but it's imperative. I've had men who are tall and skinny. I start them on CPAPs, and their testosterone now goes up naturally, and we didn't even have to do testosterone therapy. It was just truly a sleep issue. So I would say nutrition is imperative. We're going to go back to using a meal prep service, or, cutting out alcohol, stopping eating before you, 2 to 3 hours before you sleep. All of these are simple things to do. And then have your testosterone checked. And when you have your testosterone checked, I want to know what your free and total testosterone is, not just your total. I want to know what your sex hormone binding globulin, that tells me kind of how your liver, what it's doing. It makes that protein, and it helps bind the testosterone. So there's a lot of testing to be done. Unfortunately, the FDA only approves testosterone therapy if on some panels, if you're under 250, on others, if you're under 350. I'm sorry, most men need higher than 500,
Really?
500 or 600.
That was going to be my next
You were going to ask me that. Yep. And so, do they need to be in the 2000s? No. But most men feel great if we can get their testosterone between 800 and 1200. That's usually where they're feeling like their life is just back. They feel like they're 20, 30, 40 years old again.
And so that 250 to 350?
That's total testosterone.
Yeah, that's total testosterone. Is that what's considered normal on a test?
You want to know the truth? It's literally like 250 to 1,000. How can you have that big of a...
Seems like a big swing.
Yeah. So it leaves the door open to interpretation now. Yeah. So I tell most of my men, I want to see it above 500 to 600. Mm-hmm. That's really where I know that you have the protective effects cardiovascularly, brain, everything else, when your testosterone is above those numbers. And I sure as heck do not want to wait till you're below 300 to treat you.
Fair enough. So sleep apnea, you alluded that restorative sleep is really important in testosterone production. This is what I'm gathering. How would somebody know if they had sleep apnea versus if they just snored at night? Yeah, I'm a snorer, so Kelly will tell you I snore at night, but I do wake up feeling like I'm ready for the day. I'm not dragging myself out of bed, so, but what would have to happen to make me say, maybe I should.
So I love that you wear your Whoop. Your Whoop would actually tell us what your blood oxygen. It should. Okay. There should be a setting on there
for the blood oxygen.
For the blood oxygen level.
Yes, there is. Yep. So is that how you can?
Yeah, you would know because it dips. It should give you a warning if you are becoming hypoxic, meaning low blood oxygen levels. I know that, like I'm wearing an Oura ring, and it would. I've seen my patients where it shows there's a wakefulness and there's restlessness on there. So, and it correlates with a drop in their blood oxygen level, and so. So I like these wearables because they're giving us data that we can look at. The other is snoring itself. I love that you said Kelly tells you that you snore, but you're not waking up tired. You're also, if you told me you're snoring and you're feeling like you're choking, that's different.
Okay.
Just light snoring is technically not apnea.
She kicks me and I usually stop.
And then you stop. And it might be positional, right? If you're on your back.
Actually, that's really interesting because if I lay on my right side, I don't snore. If I lay on my left side, I do snore. And then I'm a big stomach sleeper too. And if I'm looking to the So I'm trying to think. If I'm laying on like my left ear,
You might.
I do snore. If I'm laying on my right ear, I don't.
Interesting. Yeah. Sometimes I'm wondering, like I look at, our, our aorta and everything, how it's kind of, looking on compression and stuff for people. When they kind of tell me this, I try to look at their anatomy. But sleep studies are so easy now to do. You can do one at home.
I was going to ask if you could do it, because I remember it was a long, long time ago, and I get heart palpitations. So and they're benign. I think it's like either a vagal thing or a parasympathetic thing. But I when I first noticed them, it freaked me out, right? And so I wore a heart monitor and all that kind of stuff. This was like 10, 11 years ago already, and they wanted me to do a sleep study. But at the time, like the worst part for me was like I would have to go to a facility, clinic, sleep in this cold bed, with this stuff all attached to me. So you can do this stuff at home now?
You can do it at home. And then if it's positive, they'll usually bring you back in now for an in-house study, because then they're wanting to go deeper. They may want to put a CPAP machine on you and see how you respond. The other thing why they might want to bring you back too is if you have something different than obstructive sleep apnea, something called central sleep apnea, and that's your brain is not telling you to breathe. So it's not like there's an obstruction that's happening and anatomically causing a low blood oxygenation, but centrally something's happening, and you're not. Your brain is literally not telling your body to breathe. And so we treat that with a CPAP as well. And there's some other ways of treating it. And there are incredible sleep physicians that are out there that I refer to. And now I will tell you, that was the biggest complaint 10 or 15 years ago, is going to a hospital-based place. It's sterile, it's white, it's scary. Like, or you might be sharing a room or a bathroom with someone and you're like, how am I going to sleep?
Yeah.
And so a lot of these places now, they look like hotel rooms, and you get your own bathroom. And so it's definitely more comfortable. Some places will allow a spouse to come with you too, or a significant other, just to make it a little bit more comfortable, so we get an adequate sleep study to know what's going on. And they're initially just kind of putting a monitor to see what your heart rate is doing and what your blood oxygen level is doing. And then the more in depth is looking at limb movements, like what's your body doing? Are you kicking? Are you thrashing? Are you twitching? And as well as an EEG on there. Are you having seizure type activity? So they can get really in depth when you do an in-house sleep study.
So interesting. All right, so continuing on the conversation about men's health, you've got these things that are I don't know if they're fads. I don't know if they're viable. So I want to get your take. We've got things you see all over social media, like cold plunge, saunas, red light. What's good? What's bad? Are they all good? Are they all bad? What's fake? What should we be paying attention to?
Yeah, I love those modalities, because what they're trying to do is reduce the stress response. So many of us are in sympathetic drive. Yeah. It's go, 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 go. And so what the cold plunge is doing is resetting that vagus nerve tone. Infrared light, helping our mitochondria, reducing the oxidative stress, reducing pain. Saunas also, like that sweating aspect is so great. So those types of things I think are very helpful, and men and women are going to usually notice if they feel better. I will tell you, men respond, I think, a little bit better to cold plunge than women do. And I think it's just a woman in perimenopause, a cold plunge, and they're already in a stressful state. So until they're feeling like they're more stable, I usually don't tell them to go cold plunge. But for men, I think those are really, really great aspects to help reset their body and to help them out. So I don't think those are woo-woo. I think they're great. I don't think you have to do the most expensive one. And I like that some of these, there's some of these franchises that are out that you don't have to then spend 10 grand and get an infrared light, in your own house. Right. If you can, great. I always tell people, please don't change a freezer into a cold plunge. I'm just always worried about the electrocution or something.
I've seen those DIYs.
Yeah. I'm like, they can run about $500. Please just spend $500 and get a legit, a legit cold plunge.
I've got one here on the back porch. I usually Wednesdays, Saturdays, and Sundays are my cardio days. So I go running in the morning, and then I usually go in the cold plunge after that. Mondays, Tuesdays, Thursdays, and Fridays are my heavy lift days, and I'm in the sauna those days as well. So
I love that you're doing that. You're alternating things, so you're not over fatiguing a muscle group, or that's great. I love that you do that.
Thank you. Because I'm a very like ritualistic person. So when I find something that really works well for me, so I'll just tell you, like the cold plunge, for instance, this was a recommendation from my coach a couple of years ago, and he said, it basically is when I first started working with them, and I have this sympathetic thing, right? I'm always on, right? I've got the podcast, the academy, the kids, life, the other business, and so I mean, I'm always go. And what happens to me from a mental standpoint with that is that I have a hard time sometimes living in the present. Mm-hmm. I'm always living either in the past or in the future, somewhere in between, but not here. The cold plunge brings me back to right now, and it slows down my thought process, which like the initial thought of that to me is like, why would I want to slow down my thoughts? That sounds terrible. But once I did it, and once I do it, I understood, okay, well, actually what it's doing is it's bringing me back to the present, where I can focus and I can think through whatever anybody is asking me or telling me in the moment to make an effective decision on what to do next. Yeah. My point in that is that I can't do it every single day, because then I feel like those effects start to wear off. So, I have to temper myself and split it up between sauna and cold plunge. Otherwise, I feel like I'm at risk either way. Yeah. What are your thoughts on that? Should somebody be doing a sauna every day, cold plunge every day, versus?
This is where I feel like personalizing it to you and your lifestyle is imperative. We don't have enough studies to really show the science of doing it every day versus every other day. But what we can do is, now that we have these wearables, is look at your HRV, look at your readiness score, your sleep score, like what works. If you do it every day and you have poor readiness scores and your HRV drops, it's probably not a good thing. You do it every other day, and you see your numbers go up. So it's personalizing it, right? So I found my routine, I love that you're doing that, is like I do almost with my trainer on Mondays and Wednesdays, almost like a modified HIIT, right? And then on Tuesdays and Thursdays, I do like yoga. And then on Fridays, it's kind of like I might just do core. I've got the app where I can just choose what exercise I want at my house. And I might do, now I love that you can do Pilates without the reformer. So there's something I'm doing. I always get on my vibration plate afterwards, because I really feel that helps me recover. And I have foam room. A vibration plate is like literally a plate that has multiple different settings, and it vibrates. Oh. And it helps with your nervous system. I'm teaching you something else today.
I've never heard of this.
So vibration plates used to just be we thought about these for, I would say like chiropractors use them quite often, because they're resetting the nervous system with adjustments. Some physical therapy places will do it because they're trying to loosen up a muscle group as they're working on it. And then those of us who really have understood the importance of muscle building and bone stimulation for osteoporosis and osteopenia reversal, we use vibration plates. So I would say in the past year, they're becoming more and more a household thing, where people have them in the house. And so you can be on one for about 5-10 minutes, and it has different settings. They're great. You can get one for under $100. Really? You don't have to get the Cadillac that's $800, $1,000.
Look what you've done. I'm going to have to add something else to my routine.
Yeah.
See?
Yeah. And they have different, and so I do that after each of my workouts. And even if I come home and I feel overstimulated, I will go stand on my vibration plate, and I just feel like it brings things down. And I incorporate breathing. I'll do box breathing while I'm on it. And because I lose count on things, if I don't have an app that's telling me how to breathe, I just do 4x4, just 4x4 box breathing, because then I don't have to worry about, is it out 5, out for 7.
And for our audience, that's 4 in, hold 4, out 4, hold 4.
Yep.
Is that right?
Yep. Okay. Yep. And it's really important to blow out through your mouth and breathe in through your nose. That's another way. Something else that I'll encourage people to have is a vagal nerve stimulator.
I've seen those. Yeah. I've seen I have never used one, but I have seen the Facebook ads or Instagram ads.
Yeah.
They just popped up out of nowhere.
Now they're going to pop up all over. So, as you know, we do treat first responders with PTSI, PTSD, and so we talk a lot about vagal nerve stimulators, cold plunging saunas for them. But it's resetting that nervous system drive, that sympathetic flight. So these vagal nerve stimulators, you can get them that are like small and handheld. You can hold it up on your vagus nerve in your neck. You can place it underneath your diaphragm. There's most of them come with a little guide with depending on how far into stress are you and where you should treat yourself kind of thing with it. So those are becoming more and more popular, and I love that. And I don't even know where we were going with this all now.
We had too much fun.
I know, we're having so much fun. So I would say someone needs to see how they feel.
Okay.
And like for me, I hate sweating, like the steam sauna, but I can do a dry sauna. So like I let people go, okay, these are the options that you have. Try them out. See how you feel afterwards. And for the first time, don't go in for 30 minutes. Go in for like 5 minutes and just see how you do it. Don't make yourself microdose. Yeah. Don't make yourself do it, and then you come out of there and you pass out.
Yeah. See, that's me to a T. I'm like, oh, somebody said I should go in there for 20 minutes a day. I start at 20 minutes. All right, I'm going to do this.
Yeah.
No, that's really good advice. So, how are you on time? I want to be respectful.
I think we're doing good if we would start wrapping it up.
Okay, cool. We'll move to wrap up. I've just got a couple more questions for you. So, we're talking about vibration plates and these vagal nerve stimulators, and I mentioned HRV, right? I mentioned my HRV is lower. I range between and have since I started wearing this between 30 and 45. I don't even know the measurement, right? But milliseconds or something like that, and I feel okay, but like it freaked me out at first because of course I Googled it and it was like, oh, you're going to die. And so, of course I was like, oh crap, something's wrong with me. And then I started to research it a little bit more, and I found an article saying that it's kind of individualistic, and I really clung to that one because it felt good.
It is.
So around HRV, just for the listeners, what is it? How can it be used in your health, and how can these things be used to help it?
Yeah. So HRV is heart rate variability. It is personalized. I mean, we kind of know the gist of it. I'm not a cardiologist or an exercise physiologist. Sometimes I'll listen to them and like, do you listen to the Huberman podcast?
Yeah.
Like he goes really into depth, and even for me as a physician, I'm like, I get glossy eyed over. I think the biggest takeaway to make it easy for your listeners who might be like me, and like the simplicity is, you want your heart rate to come down early on in sleep, because that's showing that you're not still in that fight. You're getting that restorative. You're getting to that restorative phase quicker. And then what you want is it to stay down and maybe kind of go up and down with your REM and your stage 4 and everything. But you don't want to have a huge variability at that time because you're in that restorative. You don't want fight or flight. You want restoration to happen. That parasympathetic tone to kick in. And then as you do start waking up, you want that heart rate to then come up and be ready for the day. And you want recovery to happen. So if you take a phone call that, is a little worrisome or a high-powered phone call or Zoom meeting or something, your heart rate might come up, but we don't want it up above, 100, 120, and we want it to recover quickly. So the more we exercise and the more in shape we are, our resting heart rate should be between maybe 50 and 70, 55 to 65. We don't want it to be in the 90s all day long or 100s. That's not great for our heart. And so that's where looking at the variability and what your heart rate is doing throughout the day and how you recover, or when you start to work out and you're getting into zone 2, zone 3, how fast are you recovering, or is your heart rate staying up longer and you're trying to catch your breath? That's not good. Mm-hmm. Yeah.
Awesome. All right, cool. So 2 more questions, then we can close it up. So a couple of questions I like to ask all my guests. Number 1 is, Melody, what's a truth that took you years to fully understand, but then changed everything once you did?
Personalization. That, that was huge. I think as you grow up, especially with, my parents immigrated here, I always wanted to fit in. Being different was okay. And now I grasp it. And I love when my patients are different. And I get to praise them for it and talk about it and talk about, okay, this is how we're going to personalize it for you. No, in medicine, we talk about, is it a horse or is it a zebra? Horses are more common that you're going to see than a zebra. But we also don't want to all just think of it in the same manner and just say, oh, you're just that sounds funny. Oh, you're just a horse, But personalization and really celebrating the differences is imperative. I don't want to try and fit a patient into a box anymore. And once I learned that very early in my career, that was a game changer, not only in my life, but how I practice medicine, that it has to be personalized.
Very good. What is one question that you wish more people would ask you, and how would you answer it?
Oh, wow. I needed preparation for that one, I think. Can I be successful with keeping my weight off? I love that I still have patients who started with me on their weight loss journey all the way back to 2008 and 2010. I have patients who have started with me through medicine all the way back from 2006 when I got started. And it is the ultimate just respect that I have for them for trusting me all these years and changing with me. But the biggest joy I have is helping someone keep the weight off. So when someone asks me, will I be successful this time because they've been a yo-yo dieter, I get ecstatic because my goal, what I tell them is yes. You will be successful. All we need to do is we need to figure out why the weight came on. We're going to safely get it off. And then I'm not going to leave you. You're going to stay with me. We might not be seeing each other every month anymore, but I'm your subspecialist. I'm going to be with you through life and we're going to keep the weight off.
Awesome. Where can people find you if they have more questions?
My practice is here in Gilbert. It's called Activated Health and Wellness, and I named it that because I feel like we can activate our health, and so I love that we were able to name it that. And so online it's activated.health, and we're here in Gilbert.
Awesome. Well, Melody, thank you so much for spending your time today with me and our audience. I know I got a ton of it. I got 4 pages of notes here that I get to review later and let it sink in. And I know my audience got a ton out of it as well. So thank you so much.
Thank you for letting me come on this too. It's been a pleasure. And it's I think we had so many going conversations. This is my life. This is what I love because it shows how many different topics there are to talk. It's not just what's your BMI and what's your blood pressure?
And
right?
I feel like we just scraped the surface.
Yeah.
I feel like there's so many more conversations to be had around the topics that we talked about, and maybe there's an argument one day to come back on and do a deep dive into 1 or 2 of these things.
I'd be more than happy to.
Awesome. Thank you so much.